Hey everybody, we're back with another specimen today. This is number 1414 in our collection, and we'll start off by doing a quick teaser or preview of the main phenotypic features of this heart. You'll see there's a lot of heart here, and there's also the lungs and the airway attached, so my apologies if it's a little awkward while I reposition this heart at times. But nonetheless, here's the anterior surface, and right off the bat, we see that there's some sort of conduit on the anterior surface, but doesn't appear to be coming from the right ventricle. And when we open this heart up, we in fact find that this conduit is leading blood from the right atrium to something which would have actually ended up being the branch pulmonary arteries. So it appears that this is an early Fontan, an atriopulmonary Fontan. And so then if we look for the superior caval vein, sorry I knocked the camera, here's the superior caval vein, and we find that this no longer actually connects to the right atrium. There is no direct connection, and it in fact is anastomosed to what would have been the pulmonary arteries. So we have the SVC to the pulmonary arteries, so a Glenn anastomosis, and then we have an atriopulmonary Fontan. So not a classic Fontan procedure in which both the superior caval vein and the inferior caval vein remained connected to the right atrium, but in fact, later on in the evolution of the operation, where the SVC was connected to the pulmonary arteries in a Glenn operation, followed by an atriopulmonary Fontan. And also when we look at this heart and look at this right atrium, we find that there's a blind ending to this right atrium. There in fact isn't a right atrioventricular connection, so this heart does have tricuspid atresia. But now that we've gone through the highlights of this heart and done our little teaser, so to speak, why don't we go ahead and look at the rest of the heart? And the heart would have sat roughly in the chest like this: anterior surface towards the screen, posterior surface towards the turntable, head or superior here, legs or inferior over here, left over here, right over here. Now, obviously this heart's been distorted. It's hard to find a right atrial appendage because it has been largely obscured by this right atrial to pulmonary artery conduit. But here, in fact, is the right atrium. And we can see that the atrial septum is in fact intact, which is what we would expect at this point in the staged repair. Here we find the eustachian valve, and let me try to get a better image of that. So my apologies, let me get this situated a little better. Here is the eustachian valve here, and I hope there's not a shadow. So eustachian valve here, mouth of the coronary sinus is back here. And then we can see that there is no right-sided atrioventricular junction. The right atrium just ends blindly here. So there is, in fact, tricuspid atresia. So let me show you that bottom of the atrium more nicely and see if I can demonstrate that eustachian valve here a little better. Here's the eustachian valve, and then the mouth of the coronary sinus is right in there, okay? Now, of course, arising from this right atrium is a conduit from the right atrium to what would have been the pulmonary arteries. And so this is, in fact, an atriopulmonary Fontan, which was done very frequently in the 1980s and the late 1990s. But in this case, only the inferior caval vein was draining to the right atrium. Here is the superior caval vein. And we can in fact see that the superior caval vein has no direct connection to the right atrium. And in fact, when we look at the superior caval vein, it has been anastomosed to the pulmonary arteries. So a superior caval vein anastomosis to the pulmonary arteries, what we would refer to as a Glenn operation, and then a Fontan operation in the atriopulmonary flavor, so to speak. And this heart has tricuspid atresia. We haven't actually dissected out the right ventricle. But let's go to the posterior aspect of this heart. And let's find ourselves the left atrium. And here we find an atrium that has a smooth wall, smooth vestibule, consistent with a morphologic left atrium. We can see the pulmonary vein here, draining quite nicely. Here's the right upper pulmonary vein. And we can actually also see the right lower pulmonary vein here. So not often that we get to see the pulmonary veins well. And then we can look down on this mitral valve here a bit. It's hard, might be hard to visualize, but you can look down at this mitral valve here. But we'll go ahead and look at this mitral valve from the left ventricular aspect. So here's a left-sided AV valve. It's got two leaflets, 1, 2, and it has no direct connections to the ventricular septum, consistent with the morphologic mitral valve. I'm sorry if that was blocked, so let me try to demonstrate that again. A 2-leaflet, left-sided atrioventricular valve, 1 leaflet here, 2nd leaflet here, with no direct connections to the ventricular septum here. So consistent with the morphologic mitral valve. And here is the left atrium here. And so this would be the anterior leaflet, and then this would be the posterior leaflet of the mitral valve. Now, when we look at this ventricle itself, we find that it has fine crisscross trabeculations consistent with a morphologic left ventricle. And as we look at this ventricular septum here, we find that there is in fact a VSD that's entirely muscular in its borders. So there is a muscular ventricular septal defect, although remember the ventricular septal defect type is defined from the right ventricular aspect. We haven't dissected out the right ventricle here, or opened it up, I should say. So it appears to be a muscular VSD that is in fact restrictive. Right? And then when we get to the left ventricular outflow tract here, we do find an atrioventricular valve with 3 leaflets, 1, 2, 3, and 3 sinuses, 1, 2, and 3, consistent with a morphologic aortic valve. Now, as we've pointed out with the arterial valve in the past, note that there isn't really a true round or oval annulus. The structure of the valve itself kind of has this crown-shaped appearance with interleaflet triangles interposed in between the fibrous valvar leaflets. And generally, we do see that there's fibrous continuity between the mitral valve and the aortic valve leaflets, but you can see there in fact is muscle here. And so there isn't fibrous continuity between the mitral valve and the valvar leaflets of the aortic valve here. So there is aortic infundibulum, or what some would call subaortic conus. And then here is one of the coronary arteries, one of the orifices back here. Let's see if we can find the other. Fortunately, can't at the moment. And then here is the ascending aorta. So a unique heart with tricuspid atresia that underwent a superior caval vein anastomosis to the pulmonary arteries, aka a Glenn anastomosis, and then underwent an atrio to pulmonary connection, so an atriopulmonary Fontan, but not a classic Fontan, as the superior caval vein does drain directly to the pulmonary arteries.